there, we can go ahead and get started. So we do have Dr. Ellen Lipstein with us today. I'm going to go ahead and just read off your bio and then you can take it away, okay? All right, so Ellen, sorry, let me pull it up. Ellen Lipstein is an associate professor of pediatrics at Cincinnati Children's Hospital Medical Center. Her research focuses on understanding and improving the ways parents and patients with chronic conditions collaborate with healthcare providers to make treatment decisions. Specifically, she researches shared decision-making and how it can be used to engage parents, children, and adolescents with chronic conditions in their care. Dr. Lipstein's current program of research uses both qualitative and quantitative methods to answer questions about how decisions are made, what help families need in making decisions, and how healthcare providers can better support families' decision-making. Additionally, her team is involved in the development and testing of interventions aimed at addressing the decision-making challenges.
Great, thank you so much. Let me share my screen. You guys can see those slides now. Great.
Yes.
As I go, do feel free to interrupt me. I am not very good at monitoring. Sorry, I'm trying to make you guys the right size to see my slides. I am not very good at monitoring the chat while
Ellen, I'll take care of that for you.
So feel free to speak up. So thanks for having me. I'm excited to talk about pediatric decision making oops, slides aren't moving. There we go. By way of disclosure, I did have an institutional grant from Pfizer for some of the work that I will talk about later. So the agenda for the next 45 minutes or so, first, we're going to talk about what is shared decision making so that we have kind of a basis of for our conversation. We'll talk about shared decision making in chronic conditions, and then we'll talk about some of my newer work on shared decision making in gender care. This is really kind of a 30,000 foot view. It's gonna, I don't know how your fellowship talks usually are. When I was a fellow, a lot of them were very detail oriented on methods. And this is not gonna be that. So if you want that in the future, I'm happy to come back and do that more, but that's not today. But I do think it's helpful for fellows to know a little bit about how I got here, because I think it's good to hear about different people's paths and that sort of stuff. So that's the Space Needle. I did residency and a CHEAR in Seattle. I got introduced to the idea of health services research there and applied to fellowship during my CHEAR. And I did the Pediatric Health Services Research Fellowship in Boston. This is the old State House where the Boston Massacre that helped spark the American Revolution happened. It was down the street from where I got off the T and went to my fellowship office at Mass General Hospital for Children. While I was a fellow, my research was actually focused on newborn screening. I was particularly interested in parent preferences around screening and how results impacted healthcare utilization and parents' perceptions of their children. I actually got to know Lisa Prosser through that work, which has been such a fabulous relationship that ongoing. And then after following fellowship, I moved to Cincinnati. And when I was looking for a job, there were limited jobs that year. I'm sure that sounds familiar to anyone who's job hunting right now. And I applied to Cincinnati. I thought, I'm not going to move to Cincinnati, but I'll go visit. How much could they tempt me to come? Now, 13 years later, I still am here. And when I applied, I applied for a position. I was originally in the Division of Adolescent Medicine, and I didn't really understand how my work in newborn screening was going to fit into this division. And a woman who became my good friend and mentor, Maria Brito, who was hiring, she said to me, if I were your mentor, what I would say is you need to think about what fellowship what the goal of fellowship is for you. If the goal was really to develop topical expertise and newborn screening is your passion, then this is not the right job for you. But if it was to develop methodologic expertise and understand the thinking of a researcher, then this could be the job for you. And you could think about how to take that interest in parent preferences and start to move it into a different space. And so that's when I started to learn more about shared decision-making and to think about how those ideas around parent preferences around testing really could serve me well in thinking about shared decision-making. So hopefully that helps give a little bit of background, both to understand my process, but also for those of you who are kind of in the middle here at the Boston Massacre site, part of your training, to think about things. So let's talk a little bit about what is shared decision-making and why is it important? And this is just to kind of put some background to put my research in context. I really like this definition that comes from a New England Journal paper from Michael Berry and Susan Edgman-Levitin, who are from Mass General. It says, in shared decision-making, both parties share information, the clinician offers options and describes their risks and benefits, and the patient expresses his or her preferences and values. That makes it seem really straightforward. Of course, it's not, right? Any of you who are clinicians and who may have an inclination towards wanting to participate more in shared decision-making know it's really hard. I spend 80% of my time researching shared decision-making, and then I go to primary care clinic and I leave clinic and I'm like, oh crap, I did a terrible job sharing decisions today. So it is very hard, but at its core, it has this simple exchange of information. And it exists on a continuum. So I'm actually working right now on an AHRQ resubmission that I'm submitting in a few weeks. And one of the things the reviewers were really puzzled about is like, how will you know when shared decision-making happened and what defines shared decision-making? And so in this resubmission, we're being really careful to explain that it isn't a dichotomous variable. It isn't, yes, there was shared decision-making or no, but really it's this middle part of the continuum. On the far left is paternalism, where the physician role is really dominant. On the far right is autonomous decision-making, where the patient and family are given information and then the healthcare team kind of steps back and says, you make the decision. Kind of everywhere in between is some degree of shared decision-making. And so it's really more flexible. And as you can imagine, in pediatrics, it's far more complicated than just two wedges here. But it exists in this middle here. But it's important. There's some really positive outcomes associated with shared decision-making. There have been two systematic reviews. The Stacy paper is a Cochrane review that looks at studies of decision aids. The Wyatt paper looks specifically at pediatric shared decision-making. And the Fix paper was using MEPS data. And it showed that shared decision-making, use of shared decision-making is associated with improved knowledge, increased satisfaction with decision-making, decreased decisional conflict, which has to do with the uncertainty around the decision. It isn't interpersonal conflict. A better match between informed values and choice, meaning that the patient is choosing the option that matches their values, and decreased healthcare utilization and expenditures. And I will say that a lot of this data is a little tricky to look at. There's some conflation between use of decision aids and shared decision-making, which we can talk about a little bit more later. But most of the studies look at decision aid use and don't necessarily measure shared decision-making. It also affects perceptions of care. Patient-reported quality of care is higher when they also report there being shared decision-making. There's improved rating of physician communication and improved satisfaction with care. And the most compelling reason I find to do shared decision-making is that it's just like the right thing to do. I like this quote that says, the imperative for shared decision-making rests on the principles of good clinical practice, respecting patients' right to know, and that their informed preferences should be the basis for professional actions. So the last thing I want to talk about before we move into my research is, when should shared decision-making be used? Because this comes up a lot when I'm talking to clinicians. This is one of their biggest concerns. They say, well, there's a second big concern, which I'll mention in a moment, but they say, when should it be used? It doesn't apply all the time. Like, what if there is a clear right answer? And sometimes there are. And so I like to think about this XY axis, where the y-axis is the expected strength of patient preferences. So at the bottom, you wouldn't expect someone to have a strong preference. So that might be like the brand of medication they would have, or Yeah, that's a good example. Branded medication. At the top, you would expect them to have strong preferences. That there's something about the options that would make them want differ. So an example is like for strep throat, you'd expect people to have a strong preference about an injected medication versus a oral medication. And then along the bottom is medical equipoise. And this is the idea that the options are, one option is medically more superior than the other. And so on the left side, there is no equipoise. And so this might be the idea that like you're got in a major car accident and you're dying at the side of the road. Like that is not the time for shared decision making because there's a clear right answer, like start CPR or take you to the hospital or whatever it is. On the right side is where there is equipoise. And this could happen in two ways. It could be, and this is where most of the shared decision-making literature is, it could be that there's strong evidence that shows that the medical outcomes are the same for two different treatment pathways. And this happens a lot in the adult cancer world. The other place there could be equipoise is because there isn't enough data and that we just don't know what the right answer is. And so one example of this could be like participating in clinical trial. Clinical trials, by definition, there's medical equipoise because we don't know what the right choice is. And that's why we're doing a trial. And so shared decision making happens best at this upper right corner. And where you'd expect there to be strong patient preferences and where there's medical equipoise. Does that make sense to everyone? Let me pause there for a moment and see if there's any questions.
Can I disagree a little bit?
Sure.
Right. So let's say there is a particular cancer treatment that extends life. And we would say, well, the evidence would be to go that treatment route. But the side effects of the treatment are, different than in the less life-preserving treatment. So are you saying that shared decision-making would not apply in that situation?
No, thank you for that clarification. I'm still kind of waking up this morning. As I was talking, I was thinking about examples like that. You're right and I think that's one of the examples where it's important to know what is considered the best, right? Because you're right, like it could be life-saving, but maybe that isn't the best option because of these for individual family, because of these very severe side effects. And so I agree that that's more kind of in this middle area. Sorry, I just realized I'm using my pointer on the wrong slide. I apologize. That you're right, that is an excellent place for shared decision making. And so if you would expect there to be strong patient preferences, I would say in that example, there probably isn't a perfect medical equipoise. And so the example, one of them that comes up with breast cancer, for example, has to do with whether you do mastectomy versus radiation and lumpectomy. I think I'm getting this right. I don't study adult cancer at all. And there's one where like the side effects are very different. And you could imagine though that one of those might be more life preserving than the other, and that you would still want to do shared decision making at that point. Thanks for clarifying that.
A related question having to do with decision making preference. Mm-hmm. So are you saying that in the case where the person prefers to make the decision on their own, that would not be, we would not try to engage that person in shared decision-making? Case in point, anti-vaxxers, right? They have their view, but we still try to engage them. At the other extreme, which is probably common, families will say, doctor, what would you do if this was your child? Do we substitute our judgment, our values for the family? Could you comment?
So those are two great examples. So the vaccine example, I would say, is not appropriate for shared decision making. And in fact, when we're engaging families, we're using more of a motivational interviewing approach. and that MI and shared decision-making can go in concert with each other, but that they're for different things. When there is a clear, from a medical standpoint, right? So vaccinations are the right choice. Then it's about figuring out what their barriers are and using an MI approach. In a case of like obesity, that's an example that comes up sometimes. We know that from a medical standpoint, that weight loss has strong benefits. And so getting at someone to being ready to make those lifestyle changes uses MI, but then once they're kind of there, you could use shared decision-making to figure out what approach to take. In terms of the doctor, what would I do? When I present this, I have presented a talk that's more aimed at clinicians and less focused on my research. And we give that example. And I think one of the things we really need in order to change the culture of medicine and institute more shared decision-making is we need to change our scripts. You know, we all have our spiels that we give hundreds of times in our career. And what I would say is in that, what should I do or what would you do? We need new responses. So it's not it's not I would XYZ. It is, you could respond like, well, if the cost of medication was really important to me, I might do Y, kind of getting at what their values might be. You could reflect back the question, that sometimes annoys people, why do you ask? So I think there's responses that can help people get there, because I think that question is not usually really that they want you to make the decision, but they feel overwhelmed and need different information. Thanks for these questions. I really appreciate it. Any others before I go on? Okay, so let's talk about shared decision-making in pediatric chronic conditions. So a lot of my work, which is why Jeremy and I know each other, and I ended up being invited today, largely, has been in pediatric IBD. And I think this is one of those things that's really important to think about as for fellows and junior faculty is like, why did I end up doing IBD research? So what we didn't say anywhere, sorry, I apologize, is that I'm a primary care clinician. I do not prescribe biologics, which is what much of my research has been about. I refer kids who I think have IBD to GI. But when I was starting out on faculty and started thinking about shared decision-making, I needed a lab. And so the GI team and rheumatology also here have been so generous, and it has been a great lab for understanding shared decision-making in chronic conditions. And when we started this work more than a decade ago, decisions around biologics, particularly TNF alpha inhibitors, it was one of those places where there was some equipoise in a lot of the ways that you were just talking about, in that it medically was beneficial. You saw better outcomes from your IBD if you're on biologics, but there was thought to be, and now things have changed some, a fair amount, but a risk of lymphoma associated with these medications. And so it was a very difficult decision for parents. And it also was a great place for me to be able to study shared decision-making, because our GI clinic had a great preclinic planning process, and they knew when they were going to be making decisions with families. And so I was able to really identify families early and be able to do some of our qualitative work in which we followed families through their decision journey because of this process. And so even though I did not come into it with any particular interest in IBD, it turned out to be a really great space for doing work. And so I think having that openness can be helpful. So our first studies were qualitative interviews, because no one knew anything about decision-making in this space. And in fact, at the time, there was virtually no research in pediatric shared decision-making. There's still very little, but it's growing. So in our qualitative interviews, we interviewed parents and adolescents about their decisions around these medications. So we found that parents had a lot of unmet information needs. We found that both parents and adolescents wanted to participate in decision-making, and that the role the adolescent had was not always the one they wanted. And the way we looked at that was we used these pie charts. And I know when you're projected on your home monitor, it can be a little bit small, but we asked the adolescents to draw, and these were on separate pages when they did it, how the decisional responsibility was allocated amongst people. That's the left column. and then how they wish it had been. And you can see that like the top one shows an adolescent who wished they had increased role in the decision. They said, I wish maybe they would have listened to my opinion a little bit more. The middle, they wanted less role, saying, I mean, they know, the doctors know more than I do all about all the medicine and everything. And my parents were looking up so much. Though I will say there was also a fair number of adolescents who wanted the parents to pay more attention to the doctors. They thought that their parents were spending too much time thinking about the decision and they just wanted to move on. And then there were some, this one that said like, they wanted no change. The decision to start biologics pretty much worked out exactly as I'd have liked it to. And so this was one of the first studies to really look at adolescent roles and decision-making and to think about it. Another thing we found in both the adolescent data and the parent data in these studies was we heard a lot from them about where they would say things like, well, the doctor said XYZ, or she promised that I wouldn't experience whatever. And so we started thinking about like, is this really true? Is this their perception? And so what we decided to do as part of my K was that we did an observational study in which we filmed video recorded visits in which we anticipated there to be a decision-making interaction, again, because we could predict this from preclinical planning. We then interviewed people 2, 6, and in some cases 10 weeks later to look at that decision trajectory. But also, when we started the study, the idea was that then we'd be able to look and see whether their recollection was correct. As it turned out in the second study, for reasons I cannot explain, we did not have people saying like, oh, well, she said this or he said what, that. And so we actually never did the comparison between what they said and what we observed in the clinic visit. But nevertheless, we got a couple great studies that start out there. And from the observational study, what we did, so we recorded these clinic visits. And then, although there's a quantitative way of evaluating whether shared decision-making happened in a visit, we suspected that that measure would have a significant floor effect. And so instead, we took this more detailed model of shared decision-making that at the time was called the shared decision-making model for clinical practice. And we coded the visits for each of these bullet points to look for these different areas that could be signs of shared decision-making, because we wanted to kind of get as much detail about what those decision interactions were as we could. And what we found here in this color-coded one, the green thing, which was discussing options, happened in almost all visits. The blue ones happened occasionally, like in 1 or 2 visits. So things like assessing someone's reaction to what's being said, assessing the family's knowledge, assessing understanding. And then the black didn't happen in any of the visits. And you know, just as a little anecdote, in recording visits, it can be eye-opening. We had one visit in which the physician did make a minimal attempt to assess understanding. He said something like, you guys understand? And they said, okay, or something like that. And then he left the room and our camera was still rolling. And the dad turns to the mom and says, what's he talking about? And so it was just eye-opening about how attempts at shared decision-making may really be falling flat. We then, and I didn't put in much of this data, but we then did some surveys with parents and with physicians to look at whether shared decision-making was happening from their perspective. And what we found was that 47% of parents reported shared decision-making about biologics. These were families whose child had started biologic treatment for either JIA or IBD. And 75% of physicians reported shared decision-making as their preferred approach. And yet our observation showed minimal shared decision-making. And this has been consistent in other studies as well, that reported shared decision-making is much higher than observed shared decision-making. Some of this is probably a bias in that shared decision-making has enough kind of people are aware enough of shared decision-making that there's some need to have a social bias and say that it was happening. Some of it also is that we think that things are happening that don't, or we want to, there's some recall bias. And what's interesting is that the perception of shared decision-making in at least some studies has been shown to be more important than the actual observed shared decision-making. So I think there's still definitely room to improve shared decision making, but I think it's an interesting conundrum. And in ongoing work now, future from then, we're trying to do both observed and perceived shared decision making so that we can look at that comparison. So let's talk about intervention development. So in the world of shared decision making, there's a lot of focus on decision support tools. As I had talked about at the beginning, a lot of the studies really focus on decision aids, not necessarily shared decision making. They actually measure the implementation of the decision aid as opposed to measuring whether shared decision making happened. And in fact, there's some health systems, Kaiser's one, Partners Health in Boston is one, where they have kind of triggers within their EHR. So like if you refer someone for a knee replacement, a pop-up comes up and says like, do you want to send this person a decision aid? And so this decision aid goes out. And so they've done studies based on that sort of delivery of decision aids. But decision support tools are evidence-based tools. They're designed to help patients clarify their values. They facilitate a shared, informed approach to decision-making and either complement or facilitate discussion with healthcare providers. And they come in a couple different flavors. So one is patient preparation tools. And so these are ones either on paper or most of them now are online. It used to be that Partners Health was sending CD-ROMs to families that are designed for someone to fill out, to read and often fill out something in advance of their visit. And so the idea here is to get that knowledge to patients, to inform them of the different options. They have a values clarification part of them to help people think about what's important to them. What's interesting about these, though, is that in some ways, particularly originally, now there's some part often paired with shared decision-making training, but they put the onus for shared decision-making largely on the patient, in that patient has to complete all this, and then the hope is that by being more informed and having thought about their preferences, they'll be ready to engage in a conversation. The other style of decision tool is a conversation aid, and these are tools that are designed to be used during the visit to facilitate that conversation. What's important is none of these are designed to replace the conversation with the patient. And decision support tools have been found to be effective, as we discussed before, in terms of increased patient knowledge, increased knowledge of the options, reducing decisional conflict, reducing the number of undecided patients. I'm going to skip that because I already talked about that. So our first tool that we made, I'm going to share two different tools that we've made. So this is based off of a model from the Mayo Clinic and was one of the first, maybe the very first conversation aid, but not this one, the Mayo Clinic one. And the idea here is that you have this array of cards that you show to a family. And so after you're at the point of the visit where you want to discuss the decision, you could say something like, so as we've discussed, Zoe's IBD is getting worse, and we talked about that it might be time to start a new medication. When families are thinking about starting a new medication, these are some of the concerns they often have. Would you like to discuss, which of these would you like to discuss first? And with if there's an adolescent in the room or a very capable younger kid, I encourage providers to first ask the kid and then ask the parent. In our initial testing, kids almost always chose when will it start to work, and parents almost always chose what are the side effects or what is the risk of cancer. And these cards then are designed, you can line them up side by side. And it shows the same treatment option in the same place on each card. So then you can look at these different values. And so the values clarification aspect of this tool is the choosing which card is important to you to start talking about. Certainly, if there's something that the family doesn't choose that the physician thinks is very important, like the risk of cancer, they could bring up that card and say, you know, before we make a decision, I really do think it's important that we discuss this. These cards were designed with minimal information on them so that the physicians still are providing a lot of information. We know that the physicians know a lot of this information. The other thing, to go back, one of these cards was, when will this treatment end? And that card has virtually no information on it. But we put it there to allow people to ask that question. And same with the cost information. You know, often we have very little cost information other than you need to call your insurer. And so some of the choosing of these questions is to allow people, give people permission to ask those questions that may be hard to ask. And so we ran a pilot trial of these, this tool. It was acceptable to parents and patients and most physicians. None of the physicians thought it was totally unacceptable, but their acceptability ratings were not as high. The intervention was associated with a higher level of observed shared decision-making, but no change in the perceived shared decision-making. And I think that largely had to do with this, what is the risk of cancer card. On the back of it, there's an icon array, which is a way of showing risk that gets you extra points on the observed shared decision-making scale. So there was no difference in perceived shared decision-making, decisional conflict, regret, or quality of life. But this was a pilot trial. It was not designed to show a difference. It was designed to look at acceptability and feasibility. The one thing we really learned from this was that we needed to improve training, because the biggest complaint from physicians was that it took a lot of time and that they were discussing options that they didn't think were viable options for the family. And which in our training, we had discussed that you did not need to discuss all the cards, and you didn't need to discuss all the treatments on the card. You could say, these are not a viable option for you, and just move on. But when we watched the videos of the visits, people felt like they had to discuss, and did discuss, every single card and every option on every card, which does make the visit much longer. And so we think there's opportunity to really use this, but we need to improve the training. And we'll talk a little bit about next steps in a moment. We then turned our focus, and this is the work that was funded by Pfizer, to adolescents and young adults with UC. They're a high-risk population as they're transitioning to adult care. Our qualitative work showed that they had distinct needs from younger kids or adults. As one of our focus group participants said, I think we're in a gray zone. Like, they just felt like nothing was right for them. And so we used a human-centered design approach that was led by a design team and included adolescents, which was important because the adolescents were very different things from what we planned. When I wrote this grant, I thought we were going to create kind of an in-clinic paper-based tool, much like the decision cards, but aimed at adolescents. And they made it very clear that they wanted an app. They wanted it to have like health tracking options. They wanted a social platform. They wanted a direct connection to their doctor. They wanted the data upload to the EHR. And we were able to get them some of those things. And so we developed IB Decide. So IB Decide is a web-based app that allows people to do a number of things. So one is the tracker allows you to track symptoms, so they can enter whatever symptom they want and track it over time. They can enter all their medications and put in reminders. For nutrition, they can track foods that agree with them, foods that are good on sick days. And then on treatment options, we had a couple different features that I'll show you. And then an appointment guide where they could put in their clinic visit, they could put in notes, it had some question prompts to think about before their visit. So here you can see the treatment options. We had 3 different things. So one is some basic information about ulcerative colitis, because some of our focus group participants said they've learned a lot just from other people during this focus group. And so we wanted to give them that information. A way of comparing medications. So that's on the far right, where people could choose 2 specific medications and then compare them side by side. And you'll notice that these look very similar in structure to the decision cards, and that's intentional. And then what we call a treatment generator that had, I learned the word chatbot in the development of this. And so you could answer questions. It's kind of choose your own adventure. Like, can you swallow pills? Are you comfortable receiving injections? Are you comfortable administering an injection to yourself? And then based on that, it would show you treatment options that fit these priorities. You could always go back like a choose your own adventure book and reselect to see what the other options were. And then the page that shows you the medication says, here's some options that fit what you told us. Discuss it with your doctor. This was not intended to finalize a decision, but to spark conversation. And the tracker, the symptom tracker, would let people graph multiple symptoms so they could see how they came and went in concert with each other. So we ran a pilot trial of this as well. It was highly acceptable and usable by patients. And about half the people in the trial used it very frequently, others just used it once or twice. Interestingly, the treatment generator, which was the part that we were most excited about, it was the decision aid within this app, was not used by most participants. Only 5. We could only track it by IP address, not by participant, but only 5 different IP addresses access the treatment generator out of 17 participants. And no one ever discussed that they'd used it in the clinic visit. So we had planned to look at acceptability on the part of physicians, but none of the adolescents ever opened it to the physician's knowledge during clinic or used it as part of the visit. So we had some very pragmatic lessons that we learned from this. One, design expertise is invaluable. Like, we would have gone the totally wrong way. We would have had no idea how to kind of really harness the adolescents' thoughts and expertise, but we also needed the clinical expertise and to be able to say, like, hey, we can't put in a link. We end up putting in a link to MyChart, but we can't have this data upload to the EHR at this point. We're not going to have a social function, but that back and forth was great. We also learned that web development is very expensive and slow. As I said, we put this together thinking we were going to do a paper-based tool, and then we did a web-based tool, and it cost probably 10-fold more than we planned. So over budget, and I learned Google Analytics is not straightforward. We had a lot harder time getting that data than we expected. And so our next steps for this work is hopefully we'll develop a multi-site factorial design trial that will allow us to combine IB Decide and the decision cards and look at the impact of them both separately and together. This is one of those studies that I keep saying we're going to write the grant for, and then something shinier and brighter comes up first, but it's coming. Let me pause there, and then I can talk a little bit about decision-making in gender care. Any questions or thoughts?
I do have a quick question. When you talked about like the 3 different examples of the shared decision that the adolescents wanted, for that one, what was the age range of that group that you were looking at? And then were there like specific ages that preferred one of the options over the other?
Yeah, that's a great question. So those patients were 12 to 17, and and it was small qualitative. We had 15 adolescents, so we couldn't really look at that age difference. In another study that looked at adolescents, that now I'm trying to remember, I think it was part of the IB Decide work, but now I can't quite remember where it fit in everything. But what we did find was that older adolescents were more able to think about like long-term side effects and weren't quite as quick to want to start treatment. And we also found that older adolescents, interestingly, often wanted to engage their parents more. We thought in that study, we think it may have been that they were recognizing that they were going to transition, and so kind of recognizing the value of their parents in that conversation. But there wasn't, in that study with the pie charts, there wasn't a distinct difference by age. Anything else? Great. So after 10 years of IBD work, I needed to branch out. And there were a couple of reasons. One was for my own interests, for funding opportunities, to meet the needs in other fields, because there's a lot of needs for shared decision-making across pediatrics. And also I wanted to avoid being pigeonholed as an IBD researcher. I love doing research in IBD, but I'm a decision researcher, not an IBD researcher. And that line was getting a little fuzzy sometimes. And at the time that I started this work, I was still in the Division of Adolescent and Transition Medicine, and so started working. Here, TGD, I should say, stands for Transgender and Gender Diverse. And what happened is the people who led our transgender clinic here came to me saying, hormone therapy is a really big decision for families, and we need a decision tool. Can you make one? And I said, hold on. Before we can make a tool, like, we need to understand the decision better. And we need to do some qualitative work with families to understand their process. So I really thought we were going to follow the same process as we've done in IBD. We were going to do some interviews, and then we were going to do a survey, and then we were going to develop a tool. But what we found in those interviews was there was a whole lot of decisions that people were making, decisions about disclosure and coming out, social transition, when and with whom do they use change their name, their pronouns, their presentation, and then lots of medical transition, medications and surgery. But for all of these that people discussed, and we did in the interviews, we focused on decisions about starting hormones, specifically testosterone, but we learned a lot about the other decisions in there as well. And we found the decisions were more about identity than medical risks. And in retrospect, this was really obvious when we shared this with people working in gender clinics. But it meant that the models we had for shared decision-making didn't fit very well. And so we needed to kind of take a step back and think about how you, what the data is around decision-making and how we can think about bringing together these social and medical decision-making bits. And so we took a three-part approach to this. One was a scoping review of the literature, one was interviews with clinicians, which I'm not going to discuss at all, and one was a group level assessment, which I'll talk about in a moment, with youth, parents, clinicians, and community advocates. And looking at the time, I'm going to skip forward a few slides. So we did a scoping review. Of note, we identified 4,000 papers, or actually 4,100 papers, of which 700 were in the last 18 months prior to submission, or as it turned out, it was between when we first submitted and when we got our reviewers, and so we had to do a lot of rework. It ended up including 44 papers. Of those 44, 15 focused on youth. You can see here the areas of decision focus. And 4 papers were on decision support intervention. So that was 4 papers on 3 different interventions. And our main findings were that many gender care decisions are made in the setting of uncertainty. There were challenges in balancing the decision-making roles and power between patients, parents, and clinicians. And then again, we saw this strong interplay between social and medical decision-making. As part of this scoping review, and scoping reviews use similar processes to systematic review, but are broader in what they include. So we also wanted to look at what tools were out there. And so this map comes from the Human Rights Campaign, and this is clinical care programs for gender expansive children. So we reached out to all of these clinics and asked them for the tools they use in supporting families' decision-making. We did not clarify what we meant by a tool, we just left it open. We received 150 tools from 16 clinics. Almost all of them were patient education handouts, scientific articles, consent forms. None met criteria, even minimal criteria, to be a decision aid. Originally, we had planned to only look at the ones that were decision aids, but then we didn't have any. 20 did give information about more than one option, but all the others didn't. And 7 include risks and benefits of multiple options. And so our conclusion from this was that there was limited research. We needed some well-developed decision support interventions, but it was unclear which decision needed the most support. And so to investigate that, we did a process called group level assessment. This is similar to focus groups, but it uses this very set process that leads to the group actually analyzing the data within that time period. And so we did this, we had planned to do 6 in-person groups around the Midwest, but then there was a pandemic, so we did them online. And we included transgender and gender diverse youth, parents of transgender youth, healthcare providers, and community advocates, which was self-defined. And so you can see we got pretty even division amongst those groups. Mostly people were from Ohio, Illinois, and Indiana, which is where our sites were recruiting, but we got a smattering of other people because we invited participants to forward the invite to other people. And we used this really cool program called Padlet, where you, in an in-person GLA, this would have been flip charts around a room. But here what it is we had 22 of these prompts, and people had time during this online group to go through and respond to the different prompts. They responded to the prompts. You could also respond to people's responses. You could kind of like them with this little heart. And so people had about 20 minutes to do that. And then they went back to small groups that were based upon their role. So either the youth or the parents, and we're assigned a section of these. So like maybe 1 through 7 to analyze and to look for common themes in them. Then there was large group analysis of those themes. And then we ended up with 6 kind of sets of stuff from people. And what we found was 6 main themes where people felt like there needed to be support. This was increasing access to support outside the healthcare system, improving healthcare provider skills and education, developing information resources, which is kind of where decision aids fall in, but you can see it was only one of 6 things. Supporting youth and leading decision-making about transition, which could also involve decision aids, modifying the healthcare system. And then we surveyed people who had participated in the GLAs to kind of rank these areas so we could think about where to start. And this one, improving healthcare provider skills and education, was the top ranked tool or top ranked item, which for me, I think is really interesting because I think it gives us an opportunity to really focus on shared decision-making education. And although I spent some time this morning talking about decision aids, because that's kind of where the field has been, in the long run, this is a little bit of a soapbox and a little bit of a unpopular opinion among some, but in the long run, I think decision aids are kind of a dead end, because as long as clinicians think that they need a decision aid in order to share a decision, then we haven't really gotten to shared decision making, and we're never going to have we're never going to have aids for all the decisions that could be shared. This is not to say I think aids have no role. I think that they're, for specific decisions, having some tools can be helpful, but I think we need a focus on shared decision making education. And this the findings from this transgender work suggest that in some places you could couple clinical education like gender care with shared decision making education. I think the palliative care folks are really good at this. And I think that's an areas that we need to think about incorporating better. This slide just talks about there's a lot of opportunities. There's huge measurement issues. We need effective tools, we need training, and overall we need increased focus on kids and adolescents and shared decision making. The vast majority of research that comes out is still focused on adult patients, and then the next focus in pediatrics is on the parents. So there's a lot of studies just looking at parent roles with limited focus on the kids and adolescents. So that's a bit of a whirlwind. I apologize, I probably had too many slides this morning, but do reach out at any time regarding any of this work, opportunities, if you'd like to collaborate, if you just want to like talk about research journeys, whatever, I'm happy to. I'm going to stop sharing so that I can see your faces, but I'm happy to share again if we need to. But thanks for having me.
Thank you, Ellen. So now we have a few minutes, excuse me, before we end, but if anybody had any questions, you can go ahead and unmute yourself and ask or put them in the chat.
I have another question. It has to do with proxy decision-making. So in the case of children and adolescents, you gave the example of gender care. The individual who has to sign the consent form is the parent. And parents might have a very different view about the reasonableness of their teens, young teens, decision-making. And that seems to be, and I think a lot of developmental psychologists might agree with that. And yet the model of care, which is labeled gender affirming, seems that it might be inappropriate for parents to say, I don't think my child is thinking clearly about this. So in the shared decision, so we're not shared decision making, most of the research is done in adults. So shared decision making, which is proxy, giving permission. Could you comment on the tension there?
Yeah, there's a lot of it. So I think and I think gender care is an interesting example because of in most clinics, there's a consent form to be signed, whereas they're specific to treatment, which is not the case in other places where you just kind of sign your general consent to treat, when you register at a clinic or whatever. I think that's where the education part for clinicians really comes in terms of how do you engage the parents and the adolescents. And I think in that space, it is a lot about the developing an understanding between the parent and the adolescent, and a lot of helping the parent understand the adolescent experience. And let me preface this by saying I don't work in the gender care clinic, but it is tricky in pediatrics, because whether it's gender care or IBD or anything else, ultimately, in almost all cases, for kids who are under 18, it is the parent's decision. There's actually Victoria Miller, who's at CHOP, she's a psychologist. She has suggested that shared decision-making is not actually an appropriate term to use with kids and adolescents, that she has a scale, actually, the decision-making involvement scale, which is a great tool. And she thinks the right approach is to think about decision-making involvement, not shared decision-making. My kind of take on it is that there's really a decision triad. And so there is those interactions between the parent and the patient, between the patient and the physician, and between the physician and the parent, and that all three of those need to be sharing decisions together. But there's no easy answers. And that here, it is a case in which, often in young kids, right, in proxy decision-making, it's using the best interest model. And here it is, but it's hard to determine exactly what that best interest is. And I think having it just involves a lot of discussions, and is why also in the gender space, mental health team partners in the team are so important. But I'd say they are in other places as well. I know in IBD care, a lot of teams are integrating psychologists similarly to help people figure out, help kids and parents figure out, how do you prioritize? How do you prioritize soccer versus some treatment that may make it hard to participate in your soccer games or whatever. It's a huge challenge in the field.
So I know that we are at time, a little bit over time. I don't know if anybody else had a question, but I guess this does officially conclude our seminar. But Ellen, I don't know if you have time to stay on. If there was another question, and those that needed to jump off, you can go ahead and jump off. But while we have you, I wanted to give the opportunity if you're available.
Yeah, I can stay a few minutes.
Okay.